Testing 1, 2, 3, 4. Mary had a little lamb. Howdy, Pink Meadows. Can you hear me okay? Hey, Boris. Hey, Linda. I went live. Hey, Dad. I hope you're doing okay. I went live yesterday and folks had trouble hearing me, so I'm testing out the sound. Even so, it is well. Welcome back. Thank you for being here. Hey, Jason in Naples, great to see you. Good morning, John Scapino. Hello, hello. You guys can hear me okay? The audio is still really soft. I was troubleshooting, trying to make the audio work better. Let's see what I can pull off, guys. Let's see if I boost the audio, does that help? Testing 1, 2, 3, 4. Mary had a little lamb, over. John says he can hear okay. Butterfly Angels on the road. Good morning, Sandy Barber. It's great to see you. This is fantastic. There's 76 of you that have jumped online. I'll tell you what, if we can get to an easy 80, let's go live and answer some questions while we have some coffee this morning. Good morning, everyone. Sounds good. Julie can hear me. Fantastic. Naples is in the house. OHIO. Joe Siders says that the volume is low. Trying to sort this out. We've got 77 folks who have jumped online this beautiful Sunday morning. This is Aaron Boster, hoping to go live and answer some questions as we have a cup of coffee this morning. Hello, Adam. How are you? Waving from Scotland. I'm sorry to hear that you're ouchie yaya. Scotty's in PA. Sophia is calling in from Greece. That's pretty phenomenal. Wow. Sounds like the audio is maybe a little bit better. Jason, I hear that. Let's see what we can do about that. St. Louis, Missouri representing. Good morning. As you jump online, tell me where you're jumping in from. It's amazing to watch this growing global online community grow. 81 people have jumped online. You know what time it is. Ha! Hey guys! Hello, howdy, hi. Aaron Boster here. Delighted to be with you this morning. I had an impromptu Ask Me Anything yesterday, and the sound wasn't very good. And so I was trying to troubleshoot it this morning, and I am so appreciative that 86 of you would jump online with me and help me sort it out. Even so, it as well is an amazing moderator on this channel. She's also a fantastic YouTuber, and you should check her channel out. Could you talk about strategies to manage chronic pain? That is a fantastic idea. Let's definitely discuss that right now. I'm going to start a poll. I have chronic pain. Let's see. We'll start this poll as soon as I can hit all the correct buttons. Let's see, in the chat, I've posted a poll asking you if you experience chronic pain. Please take a moment and answer that question. As we answer that question, let me try to take a shot at discussing strategies for managing chronic pain. So the first thing to talk about is that pain is unfortunately very common in the setting of MS. I've actually had professors back when I was in training tell me that MS didn't cause pain. These are the same professors that told me that MS only affected white women and only affected white matter, didn't involve gray matter, and only involved T cells and not B cells. They were wrong on many, many fronts. I was in a lecture with 180 students total. This is my med school class, and the professor was lecturing to us on multiple sclerosis, and he said that MS does not cause pain. And I raised my hand, which was not a normal thing to do in medical school. And he said, yes. And I stood up and I said, "Sir, I think that MS does cause pain." And he said, "You're incorrect, sit down." Well, he was wrong. I knew that he was wrong because my uncle, Mark, had horrible MS-related pain. And I didn't think my uncle was making it up. And I was a little bit embarrassed that he called me out and told me to sit back down. But the bottom line is, if we fast forward 30 some years, I've been doing MS neurology now for, 20 years basically. And I can say with authority that MS does in fact cause pain. In fact, MS causes a lot of different kinds of pain. And let's talk about it for a little bit. Multiple sclerosis can affect with any of the functions of the central nervous system, brain and spinal cord, optic nerves. And so you can see in issues with the sensory systems of the body. When I touch my hand, that sensation is going through a nerve, and it goes into my spinal cord, and it goes up into my brain, where my brain interprets, hey, the hand is being touched. And that's called a sensory pathway. And in the setting of MS, when you have damage to the brain or spinal cord, that pathway can get jacked up. So the sensation on the hand can be normal. When it gets to the spinal cord, it can get kind of perturbed. And so the message that goes to the brain is not a normal message. It's an ow or yah. And this is unfortunately very, very common. Now there's some terms I want to introduce. Dysesthesia, that is a Scrabble word. Dysesthesia means a painful numbness, like a painful sensation. Another one that I want to introduce, allodynia. Allodynia is a doctor term which means that light touch hurts. A very particular kind of allodynia, let me see if I can type here, dyspareunia. And I may have spelled dyspareunia wrong, so if I did, please accept my apologies. Dyspareunia is where sexual sensation hurts. And unfortunately, allodynia, dyspareunia, dysesthesia, these are all very, very common in the setting of MS. When someone with MS has an optic neuritis and their eye nerve, the optic nerve swells, when they move their eye, it hurts like the dickens. When someone with MS has inflammation of their spinal cord and they bend their neck down, they can have electric zaps that zap down their back. It feels like they're being electrocuted. And that's called Lermit's phenomenon. We've talked about sensory changes with allodynia and dyspareunia and dysesthesia, but that's not the only kind of pain that someone with MS can experience. We can also have the MS hug, the only hug we don't want. Let's write that down. MS hug, the only hug we don't want. We should make a shirt that says that. The MS hug is a situation where the spinal cord sends a fake message and causes the muscles between the ribs to contract. So think about this with me. Here's a rib and here's a rib. In between the ribs are the rib muscles. And I'm not trying to be gross, but they're delicious if you buy some at the grocery store. But when they're intact on your body and those rib muscles contract, they squeeze your ribs down together. And it literally feels like you're being squeezed. Oftentimes people will describe feeling like they're having a heart attack, or they feel like the bra's on too tight, or they have a lasso wrapped around their waist, or they're in a vice. And that is a unique kind of pain, which is seen, unfortunately, all too common in the setting of multiple sclerosis. Now, I threw a polling in the chat, and so if you haven't answered the polling question yet, please take a moment and do so. The polling question was, do you experience chronic pain? And so right now there's been 104 votes, but there's 130 of you that have jumped online, by the way, thank you. So please take a few more minutes and answer the polling question before we read out the results. That was a great way to start this discussion. I wanted to check in with you guys. Can you guys hear me okay? Yesterday I did an impromptu Ask Me Anything, and it was too quiet. And I wasn't sure why. I'm not very good at this audiovisual stuff. I kind of hack and slash my way through it. And so I've tried to adjust the audio. Joe Siders, one of our amazing moderators, says that it's still kind of quiet. And let me see if I can boost that any further, Joe. Let's see. Testing, testing. 1, 2, 3, 4. Mary had a little lamb. Over. Okay. So some people are saying they can hear me okay. Some say it's a little bit quiet. Let's switch. We'll end this poll. There are 143 of you that have jumped online. By the way, thank you very, very much for joining me this morning for this impromptu coffee talk. And 124 of you have answered my polling question. I'm going to close the polling question in just a few short seconds. And the question was, I have chronic pain, yes or no? Now, 60% of the people that have jumped online have chronic pain. And I think that's very, very indicative of what we see actually in the setting of multiple sclerosis. Death Possum says, it's Sunday morning, laugh out loud. That's a great name. Just Saying shares that their daughter, who is 43 years old, was diagnosed just a year ago and really having a difficult time finding quality care in the Bay Area. California has some really big institutions. UCSF is a really, really big institution, and it's a powerhouse of MS research. There are a few doctors at UCSF that I'm friends with that I think are phenomenal human beings. I've never been in clinic with them, but I can only imagine that they provide outstanding care. Len likes this cup. Thank you very much. I love this cup also. I also love the Java that is in this cup. Karen Tweed says, hello, howdy, hi. Well, good morning. So Liam shares recent scan NEDA 6 years after Limtrada. And my decision started with your videos. Wow, that's really, really cool. So Liam, I am super excited to hear that. NEDA, no evidence of disease activity, is one of the metrics that we use when we're trying to assess response to therapies. NEDA is not the end-all be-all, but it is really, really important. Let's talk about something that I think is very, very exciting. There's a definition that I'm very fond of, which is defined as 5 years of no disease activity without treatment. I spelled treatment wrong. You should be very concerned. So what is this a definition of? 5 years of no disease activity without treatment. That is the oncologic definition of, if I had a drum roll, I would hit it, remission. So that is the oncologic definition of remission. Now, when I entered into the MS space, taking care of people impacted by MS and taking care of families impacted by MS, there was no term of remission. That wasn't a concept. That wasn't something that we would dare ever talk to someone about. And nowadays, that is a reality. It's not a reality for everyone, but there are some people who actually meet that definition. And Liam has met that definition. So if you take a discontinuous therapy like Limtrada, like Mavenclad, and then you're not required to take more treatment and you haven't had any new disease activity going out 4 years, we meet the definition of remission. Now, remission does not mean cure. We're not curing the disease. We've put it into remission. It does not mean that you couldn't have new disease activity down the line, because you could. But remission is exciting. Remission is something that I never ever thought that I would be able to talk to a patient about. And I am so excited that Liam has achieved that. That's really, really cool. Let's keep on keeping on. Jenny, it's really nice to hear from you, and thank you for being here with us today. Looking for another question, as this is an Ask Me Anything impromptu live stream. There's 138 of you that have saw fit to jump online. Thank you very, very much. This channel is special. It's something that I have grown to really, really value and love. It's not just a mechanism by which I hope to up your game, a mechanism by which I hope to educate, empower, and energize. It's also a growing global community, and it warms my heart. Now, Van Trotter is in the house on Mavenclad, some reversal of symptoms. That's amazing. I am delighted to hear that. Welcome, everyone. Welcome, welcome. The Mask says, most thing I have heard, smoking helps MS to go to sleep. I do not recommend smoking stuff. I do not recommend taking a carbon-based something, whether that be cannabis or whether that be tobacco, and lighting it on fire and then sucking in the smoke. That's super pro-inflammatory. It's pro-inflammatory to your lungs and heart and blood vessels. It's also pro-inflammatory to your brain. Carrie Perry says, Heidi Ho from a small town in Indiana. Hello, Carrie Perry. Listening, getting ready for church. Thank you for doing that. I am grateful that you're here with me today. So here's a question from Carrie Lucas. Is there a particular DMT that you recommend for people experiencing a lot of PIRA? That is a really good question. Transparently, Carrie, I'm not sitting here with a magic answer, all right? I will share with you that I've had some success with B-cell depleters. I will share with you that to a lesser extent, I've had some success with Tysabri. I've probably had the most success with Limtrada in trying to treat PIRA, but I think that that is an unmet need largely in the setting of MS. Now, not everyone who's listening right now might be completely familiar with the term PIRA. So let's just write that in the chat. Progression independent from relapse activity. So that's PIRA, progression independent from relapse activity. If you notice spelling errors, sorry. PIRA is a term which has become more accepted in the MS community of recent. And it's a reference to the fact that people impacted by MS can develop neurological worsening from one of two ways. One way that people can develop worsening in MS is they have an attack and they don't fully recover, and they're left with a residual deficit. So for example, they have an optic neuritis and then they can't see very well, and when the vision returns, it only returns 50%. And so they're left with a visual deficit. They're left with some raw relapse-associated worsening. So I'll throw that in the chat. Relapse-associated worsening, raw. And the second way that people impacted by MS can get worse is from progression, which is independent from relapse activity, or PIRA. And this is something which is unfortunately common in the setting of MS, and it's unfortunately not fully recognized by all treaters. And it can lead to some very, very frustrating situations in clinic, where a patient will say, I'm not doing very well. And the doctor will say something to the equivalent of, honey, you're doing great. The MRI looks stable, which is always wonderful. It is wonderful that the MRI is stable. And they'll say, yeah, but I'm not doing well. And they'll say, sweetheart, you look good. Your exam's unchanged. And it's good that the exam's unchanged, but it does not detract from the fact or reverse the fact or remove the fact that person is having increased difficulty with the litmus test of life. They're having some progression of neurological disability in the absence of treatment. And so the question that was posed is, what can we do about that? The number one thing that we can do is we can be proactive. The more proactive we are with MS, the better off we're going to be, and the less likely that we're going to see progression independent from relapse activity. What do I mean by that? I mean that if we can identify MS as early as possible, and if we can start you on the most effective disease-modifying therapy that you're comfortable taking as early as possible, we are going to set the stage so that you do not develop new neurological deficits moving forward. I'm not selling snake oil. I'm not saying that for limited time only for $9.99 if you sign up now, that we can guarantee that, not at all. But what I'm saying is if we can prevent new neurological damage, new brain and spinal cord damage, we can help set the stage so that we have less disability as we move forward in time. And it's inadequate, I say, inadequate to just take a medicine. We have to go above and beyond that. We have to have a lifestyle where exercise is in the forefront. We have to eat smart. We have to avoid smoking and other cardiovascular risk factors. We have to practice mindfulness and other stress management mechanisms. And if we apply these tenets, being 5 for 5 in your fight against MS, we set the stage so that you can have the best disease course possible, meaning the most quiet disease course possible. That was a fantastic question. Thank you for asking it. All right, let's look for some more questions in the chat. I hope that you guys are able to hear me okay. Yesterday I jumped on live and my sound was not awesome sauce. It was really struggling, and so I tried to tweak some things in the background. I'm hopeful that you can hear me a little bit better now. So Green Plastic Whistle is a great name. Thank you for being here with us, Green Plastic Whistle. Green Plastic Whistle writes the following question. Could relapse timeline of 24 plus hours not be applicable in all situations? Over time, I've had many new small symptoms that come and go in under 24 hours, sometimes hours, sometimes minutes. So let's talk about that. And I want to discuss the difference between an MS attack versus an MS pseudo-attack. So what is an MS attack versus an MS pseudo-attack? And by the way, if you like what we're doing here, go ahead and hit that like button. It teaches the YouTube algorithm that you dig what we're doing. Also, if you hit those hearts, that is another way to signal the YouTube algorithm that this is of value to you and helps push it out so more people impacted by MS can benefit. So go ahead and show some love if you're feeling the love while I answer this question about MS attack versus MS pseudo-attack. So what is an MS attack? A flare, an exacerbation, a relapse. It's all the same thing. An MS attack is when there's new inflammatory activity by cells, naughty autoreactive cells that are in the bloodstream, and they cross the blood-brain barrier where they gain access to the brain, and they cause new bouts of inflammation in the central compartment, which results in short-circuiting of function. That's a new MS attack, and that's caused by inflammation, and inflammation does not go away in 24 hours. My common example is if you got mad at me and socked me in my jaw and my face got all puffy, tomorrow my face is more puffy. Why? Because inflammation does not go away in 24 hours. My face is going to be puffy for on the order of days to weeks because of the inflammation. When you have new MS inflammatory disease activity, a new MS attack, you will have inflammation in the brain or spinal cord or optic nerves, which is short-circuiting part of your nervous system, and we will typically see deficits that last for longer than a day, hence the 24-hour rule, which is what Green Plastic Whistle was referencing, the 24-hour rule. What about things that last less often? What is that? I am most suggesting that that is not a new MS attack. It's actually what we call a pseudo-attack. So see that word pseudo, P-S-E-U-D-O. Pseudo is Greek for similar to, but it ain't, all right? And a pseudo-attack is a very, very real event. Don't you dare let somebody tell you that a pseudo-attack's not real. It is real, but it's not caused by new bouts of inflammation. It's caused by old neurological damage, which has short-circuited. And we can see this all too often in the setting of I get overheated, I am exhausted, I have stayed up too late last night and I don't have energy today, I have a fever, it's during the menstrual cycle, there's a significant psychosocial stressor. Any of these things will cause the nervous system to temporarily short circuit. And when the nervous system temporarily short circuits, you can see a transient deficit. I'll give you a very easy, I shouldn't say easy, I'll give you a common example where as the day proceeds, as you become more fatigued, as you become overheated, you don't think as sharply. You have sort of an emergence of cog fog. And then when you take a nap or your body cools back down, you're back in the game. Now, one of our OG viewers, I just watched her jump on. Let me see if I can find her. There you are, madam. Everybody wave to face. This is a wonderful human being from Jerusalem who has been a follower on the channel for some time. I am delighted that you are here with us today. Thank you very, very much for being here, and greetings to you and yours. Bluthton, one of our OG moderators, has joined us. Writes the US, Canada has wide distributions of ethnicities as compared to other countries, statistically significant differences in presentation of disease. And so when I was in training, Bluthton, I was told, actually when I was in med school, we used to say MS is a disease of young white women. And we thought that there was a prevalence of multiple sclerosis amongst Caucasian folks. That's not true. Turns out to be false. Amongst many things, we were wrong. So the incidence of multiple sclerosis is not lower in the setting of being a different ethnicity, for example, being African American or being Asian American or being Hispanic American. It's that those populations, there's less humans. And when you look at the incidence, it's actually the same across those groups. We used to think it wasn't. One thing that is 100% true, however, is that ethnic minorities, as I've suggested, have a more aggressive disease course. So sometimes nature's too generous. And if you look at a population of African Americans compared to a population of Caucasian Americans, you'll find that the African Americans tend to have more aggressive disease. Now, when someone is sitting in my clinic, they're not a group of something, they're one individual human. And it doesn't mean that they are guaranteed to have a better or worse disease course. But it's very relevant as we try to game out prognostic factors. So I really appreciate that question, and I, of course, appreciate you being here. Toy Van Totter says, hello, howdy, hi from South Africa. Wow, that's amazing. South Africa is on my bucket list. I have never been to South Africa, but I would like to very, very much. It's a place I hope I can visit. Looking along here, I'm looking for some other questions. I am so excited that there's 170 of you that have jumped online today to have a cup of coffee with me this morning and answer your questions live. Carl writes in and says, hey, any thoughts on BTK, Doc? So first of all, when we say BTK, we do not mean bind, torture, kill. We're not referencing a serial killer from, I think, the 70s or 80s. The very first time that I mentioned to someone, oh, I'm studying BTK inhibitors, and they said bind, torture, kill, it scared me. But when we say BTK, we're talking about protein tyrosine kinase. So the protein tyrosine kinase I. See BTKI? The I is inhibitor. So what is a BTK inhibitor? So when you have a B cell, so imagine like the cell is like this circle here, okay? And you stimulate the B cell. Inside the cell is a bunch of different mechanisms, a bunch of different, if you will, like machines in a factory. So stimulating the B cell triggers machine A to B, B to C, C to D, and then it culminates in the B cell communicating with something outside of it. And each of those little machines, which are actually enzymes, are required for the B cell to work properly. So the protein tyrosine kinase is one of those factory machines. And when you take a BTK inhibitor, you inhibit the machine. You break the machine. So now, when you stimulate the outside of the B cell, and you start the cascade of A to B, B to wah, you break the BTK inhibitor, breaks the BTK, and it results in the B cell not being able to communicate. And it's not just on B cells. We also see BTK in microglia. Microglia are part of the immune system, but they're not part of the adaptive immune system that we talk about all the time in MS. They're part of the innate immune system. And they're not part of the cells floating around in the periphery, in the bloodstream. They're literally resident inside the brain. And so when a human takes a BTK inhibitor, which is a pill, and it goes in and it inhibits the communication inside the B cell and inside the microglia, that dampens the immune response. And BTK inhibitors have been used in the setting of cancer rather effectively, and we're currently studying them in the setting of multiple sclerosis. So the question was, are there any updates or any new thoughts on BTK inhibitors? And the answer is no. And the reason I say that is we're right in the middle of studying them. So at the Boster Center for MS, I'm putting a Boster Center shirt on, woohoo! At the Boster Center for Multiple Sclerosis, we're running multiple MS clinical trials, about 15 or 16 right now. And several of those clinical trials are studying BTK inhibitors. They're studying different flavors of BTK inhibitors in the context of clinical trials where people from Central Ohio have signed up at my clinic to participate in this research endeavor to figure out if BTK inhibitors are better than standard of care medicines. Now, when you do a clinical trial these days, the trials run for a minimum of 3 years. And we're just now starting to wrap up a couple of these trials. And the jury is still largely out. Thus far, there has been 1 of 5 trials that has read out top-line data, and much to our chagrin, it didn't do what we wanted it to do. It did not demonstrate that it was better than standard of care. But wait, we have several other clinical trials that are still in investigation, and we don't know yet. So we don't have any new information because we're literally in the window where everything's quiet and blinded, waiting for the trials to complete so that we can collect all the information. We are going to be getting readouts on BTK inhibitors over the next couple years. My fingers are crossed that they will become an outstanding addition to the MS armamentarium. We've got a member from Germany here right now. Thank you very much for being here. I super appreciate you guys participating. We've got Doug Tagg, an OG moderator. I am so glad to see you here today, sir. Thank you for being here with us. And Doug writes, currently on Ocrevus, the cost may be prohibitive this year. The rest of the question is, can I discuss this with my neurologist? Can I discuss alternatives? And the answer is yes. There are many different ways to skin a cat. So they say. I have no idea how to skin a cat, nor would I want to. In fact, as I say that, I'm going to grab a cat who is hiding behind the monitor and bring him into view. This is Mewtwo. This is my son's ragdoll cat, and he is a beast. And Mewtwo will help me answer this question, Doug. So there's a lot of different things that we can do in the setting of financial constraints. For example, we might check your B cell levels and see if we could get away with dosing you once a year. We might see if we can get funding sources to help cover the copay costs of the Ocrevus. We might see if we can switch you to something else which is going to be better covered by your insurance product or elsewhere. Mewtwo is not very happy sitting here, and so I'm going to let him go. I'm not sure he helped answer that question at all. Pregnancy and breastfeeding on Kesimpta. And so most people impacted by MS are women of childbearing potential. And so when is the right time to ask someone about their pregnancy plans? It's typically when you meet them. It's very helpful for us as MS neurologists to have a sense of what the plans are for conception and for family planning. And we used to be very, very concerned about needing to take someone off all their medicines so that they could safely become pregnant. We've learned more recently that it doesn't have to be so binary, yes or no. And there's a couple different ways of navigating this. And so let's try to answer this question. One of the things that you can do in the setting of MS disease-modifying therapy is you can stop a B-cell depleter at the time of conception, allow the person to become pregnant, allow them to gestate, allow them to deliver and breastfeed, and then jump back into B-cell depletion. And the data that I'm referencing is not from Kesimpta, it's from Ocrevus. And the reason that's relevant is Kesimpta is out of the body much, much faster as compared to Ocrevus. And so there's a great French study which looked at giving people Ocrevus, stopping, doing the pregnancy thing, and then restarting. And it worked remarkably well. I believe that you probably could get close to that with Kesimpta, but I think using a medicine that sticks around longer might have a potential advantage. AC asks if Mewtwo is a reference to the Pokemon. It 100% is a reference to the Pokemon. That is exactly right. Phage says that she misses River, and I miss River very much too. Many of you who have followed the channel for years know that my dear and very, very sweet pet River has passed away. It's much to my chagrin. She was 9 years old, which for an American Mastiff is quite old, and I miss her very, very much. So thank you for thinking about her. All right, let's take another question from the audience. So Krista Lee asks, speaking of Kesimpta, do you recommend every 28 days or on the same day every month? It's my recommendation that when we take Kesimpta, which is once a month shot, that we take it about once a month around the same time. So for example, the first of the month or the 15th of the month. And if you do that, some months you're going to be slightly longer or slightly earlier, but I think it's easier to remember. And there is not a concern in my mind if you were 2 days late, so if it's the 31st versus the 30th, that's not going to throw you into a tailspin. Now, I'm not speaking for your clinician, and of course you need to ask your doctor about the way that they want you to navigate, but with my patients, I don't have a problem with that. Here's a question by Len, who says, what are your thoughts on Zeposia? So Zeposia is a pill taken for multiple sclerosis. It's a pill once a day, and it's what I call a Me Too drug. So there's a drug called Gilenya, fingolimod, which came out in 2010. It was actually the first pill to be approved for MS. And it's now an old drug. It's now gone off patent, and it's now available generically. And there are several Me Too drugs. Zeposia is one of them. Ponvory is one of them. Mayzent is one of them. And these are all the same class as Gilenya. So that would be like saying Coke is similar to Pepsi, RC Cola, and Mr. Pibb, right? So those are all similar colas, and Zeposia is like Gilenya. Zeposia is still on patent, which means that for those that are eligible, there's copay assistance, which is a really, really big deal as we talk about the finances of multiple sclerosis. Zeposia does not, in my opinion, bring other things to the table that Gilenya does not. I place Zeposia from an efficacy standpoint in a middle tier. It is a good, not great medicine. It is not a bad medicine, but it is not remarkable. In fact, I think it's solid at controlling relapses. I think that it's solid in controlling new enhancing lesions. And I think that it's so-so as it relates to brain volume, and I think it's so-so as it relates to progression of disability. There are medicines, in my opinion, that are superior to Zeposia. And so if I'm picking a medicine with a patient, I want to put them on the most effective disease-modifying therapy that they're comfortable taking. And if the only thing that they're comfortable taking is a Zeposia or an S1P receptor modulator, then I respect that. Although I would reach for something that does a bit better at controlling progression. And that's just my opinion. It doesn't make me right. It just makes me very opinionated. Let's keep on keeping on. So WA46 asks, do you recommend any supplements or pills for MS cognition symptoms? I do. In fact, I have a bunch of videos on my YouTube channel talking about cognition and cog fog and cognitive fatigue in ways of upping your game. And I think one of the most important things that we can do as it relates to pills and supplements is actually to focus on food. And if you have opportunities to clean up your diet, I think that it's a really, really good idea. I want you to make sure that you are adequately hydrated. And you're thinking to yourself, what? But the reality is that being dehydrated is going to make you think less clearly. And so I want you to up your water game. And I want you to pay attention to the food quality. So if you are living on McDonald's and if you're living on soda pop, you are not doing all that you can to help with cognition. And avoiding sugar, avoiding fried foods, sugar-laden foods, high fructose corn syrup, avoiding fast food, heavily processed foods, and avoiding foods with ingredients that you can't pronounce is one of the key elements to upping your cog game. If you don't believe me, try it out and you'll be shocked at what you discover. I would really start with my supplementation by improving the quality of the food that I eat. Now, there are some things that can help with cognition, some supplements and pills, but the first thing that I would like to talk about is not adding, but subtracting. Because many of the medicines that doctors prescribe, many of the medicines that we prescribe, for example, for bladder or for pain or for spasticity or for insomnia, these medicines can actually negatively impact thinking and memory. And so if we find ourselves on one of those medicines and we have side effects, it might behoove us to take the lowest dose possible or to remove it and switch it with something else. And of course, I am not telling you to manipulate your medicines just based on what I'm saying. I am instructing you that you should talk to your clinician about going through your med list and trying to streamline it the very best you can. Because if, for example, you're taking an antispasmodic before bed, something like a Xanaflex or tizanidine, and you're waking up a little bit groggy and impaired, well, that might not be the best option for cognition. And if we were able, with our clinician, to lower that dose or to switch the medicine, we may find that we can actually improve cognition through those means. Now, to answer your question more directly, there are some things that we can take. And again, I don't want you to do any of these without talking to your provider. I'm not giving out medical advice right now. I'm just educating. At least that's my hope. And you can do things like supplement with levocarnitine. So levocarnitine, also called L-carnitor. Levocarnitine is an amino acid. So it's one of the building blocks of protein that you find in steak. And there's some studies done that look at levocarnitine 1 gram twice a day. So that's 1 gram BID is doctor talk for twice a day. And it found that that helped with energy levels. And that includes, in my experience, cognitive energy. We also may find that by supplementing a B complex or omega-3 fatty acids, we also might see some benefits. Now, that's my opinion. And again, it doesn't make me right. It just makes me really, really opinionated. So thank you for asking it. So Joe, thank you very much for bringing this up. Joe is one of our amazing moderators and a really cool human being with a really, really cool family. And Joe is reminding us that the Boster Corner is out there. If one of the moderators could track down a link to the Boster Corner, I would be grateful. What is the Boster Corner? It's a monthly newsletter that the Boster Center for MS puts out. It helps bring you up to date on all the latest and greatest in the research endeavors and what's going on at our clinical center. And it lists when we have our monthly live streams. So today was literally an impromptu Ask Me Anything MS, just to have a little coffee with you guys. But once a month, I formally go online. I typically do this on the last Saturday of every month. And the goal is to up your game, to energize, empower, and educate. It's something that I'm very, very passionate about. It's something that I really love to do. And if you sign up for the Boster Center for Multiple Sclerosis's newsletter, the Boster Corner, you'll get a monthly update that gives you when and where and why and when, and so that you never miss any of our live streams. Now here is an awesome sauce question. How does MS, NMO, and MOG differ? And that is a really, really good question. Before I answer that question, let me hit a poll. Let's see here. So I have heard, I am familiar with NMOSD and MOG. Yes or no? All right. So I just threw a polling question asking if you're familiar with NMO and MOG. So take a moment and answer that question. In the meantime, I am going to go fill up my cup because my coffee runneth low. Please don't run away. There's 169 of you on right now. I'm going to step away. I'm going to make a hot cup of Java. I'll be back in literally just a few short seconds, and then we can keep on keeping on. All right? So I'm switching for a bio break. Do not run away, pretty please. I'll be right back to answer that question. And in the meantime, please answer the polling question, whether or not you are familiar with the NMOSD and MOG. I'll be right back, guys. Don't run away. Howdy, hi. I am back. Thank you very much. Thank you for waiting for me while I got a hot cup of Java. I appreciate you guys not running away. And I appreciate you being here with me today for this Sunday impromptu Ask Me Anything live stream. We had a fantastic question from Sean L., who wrote, are you familiar with, or what's the difference between MS, NMO, and MOG? And I asked a polling question, and I'm not surprised by the answer. So there's 115 of you who have answered the question. If you have not yet answered the question, if you're familiar with NMOSD or MOG, please take another moment or two and click yes or no and let us know if that's something that you're familiar with or not. There's 115 of you. I'll give it a few more moments before I close the polling question. 119 of you have answered. 122 of you have answered. Do you think that we can get up to 130 before we close the poll? If you haven't answered the poll, take a quick second and click the button. And we've got 125 who have answered. We just need 4 more. We've got 126, 127. Can we get 2 more to get to 130? I'll give it another second or two while I have a sip of Java. 129. There's 129 of you. 130 have answered. I'm going to close the poll. Thank you for participating. The question was, are you familiar with NMO and MOG? And 80% of people said that they weren't. And that gives me an opportunity to talk about a cousin, actually 2 cousins of multiple sclerosis. One of them is called neuromyelitis optica spectrum disorder, NMOSD, neuromyelitis optica spectrum disorder. It used to be called Devick's disease. So I'll put that in the chat. So Devick was the neurologist that first described this in the medical literature, at least named it after himself, because that was all the rage back then, to have old white guys name stuff after themselves. And NMOSD is a cousin of multiple sclerosis. So neuromyelitis optica, if we break that down, neuromyelitis optica. So if you look at that word, NMO, neuromyelitis optica, the myelo means spinal cord. Itis means inflammation. So myelitis means inflammation of the spinal cord. Optica is a reference to the optic nerve. So neuromyelitis optica, when it was first described, was a condition which reminded us of multiple sclerosis, where someone would have recurrent bouts of optic neuritis, inflammation of the optic nerve, and myelitis, so inflammation of the spinal cord. And neuromyelitis optica spectrum disorder has now been expanded. So we now have a better term for it, NMOSD. The SD equals spectrum disorder. Why do we call it neuromyelitis optica spectrum disorder? Because it's not just optic neuritis and transverse myelitis. You can also have involvement of the brain stem, you can have involvement of the top of the brain, but it is not multiple sclerosis. It's a cousin of multiple sclerosis. The underlying pathology of NMOSD is different than MS. And in some ways, it's more severe. It's true. So both multiple sclerosis and NMOSD can cause optic neuritis. Both MS and NMOSD can cause transverse myelitis. You can see that in both cases, but they're different. When someone with multiple sclerosis suffers optic neuritis or transverse myelitis, particularly early on in their disease course, they tend to make a very meaningful recovery, sometimes a full recovery, but oftentimes they recover significantly. Not so with NMOSD. Oftentimes, when someone suffers an optic neuritis from NMOSD, they're left blind or nearly blind. When someone has a transverse myelitis, more than half the time, they're left with devastating permanent deficits in strength and in sensation and in difficulties with the down theres. And so in many ways, NMOSD, when someone has an attack, is much more severe than when someone with MS has an attack. Now, that is not always the case. It's not like one size fits all, but generally speaking, the attacks of NMOSD are more severe. There's another really big difference with NMOSD and MS. In multiple sclerosis, between attacks, we can have PIRA, something that we discussed on this channel, on this live stream, not just a few minutes ago. And PIRA, progression independent from relapse activities, is a way of saying that someone with MS has an attack, hypothetically over here, and then there's a period of time, hopefully years, before they have another attack. In that time in between, the person with multiple sclerosis can see a progression of disability. They can get worse without an attack. We do not see that with NMO. Generally speaking, between NMO attacks, the disease is completely quiet. We don't see PIRA. Now, as I alluded to earlier, MS and NMOSD are not the same disease, and they don't have the same pathology. In the setting of multiple sclerosis, the primary attack occurs on the oligodendrocyte. That's the cell that wraps the plastic coating around the wires. That's that fatty coating called the myelin. And it is the primary target in MS. It is not the primary target in NMO. In NMO, the primary target is a helper cell called the astrocyte. And the astrocyte is under attack from the immune system. And when the astrocyte blows up, there's bystander damage. And so it can hurt other cells nearby, like the oligodendrocytes and the neurons, and those are secondary damage. And so it's different in its pathology, it's different in its presentation if you think about it, and there are different treatments for NMOSD. Now, NMOSD is not as common as multiple sclerosis. So in the United States, we calculate that there's about 1 million people that have MS and less than 17,000 that have NMOSD. So it's not as common. But it is a very, very important thing to understand because oftentimes people with NMOSD might be misdiagnosed initially as having MS. And the MS medicines don't really work to help NMOSD. Most of the MS medicines, when we've tested them, do not work to treat NMOSD. And so having the correct diagnosis is critically important so that you have the proper treatment algorithms available to you. If you're curious about NMOSD, I have made a few videos on my channel. I actually have an NMOSD playlist. I don't know if any of our wonderful moderators might be able to go through the channel and dig up a link to that playlist, the NMOSD playlist, and put it in the chat, and that way you could click it and learn about it. There's another condition which we asked about, which was MOG. And MOG is a cousin of NMO. MOG mostly affects the optic nerves with recurrent bouts of optic neuritis, and it can less likely affect the spinal cord. And it's a cousin of NMOSD. There's different antibodies involved. And the treatment for MOG is less well understood, although oftentimes we can use the same medicines that we use for NMOSD, although the fave medicine that we use to treat MOG is IVIG. So if you guys are interested in learning more about cousins of multiple sclerosis like NMOSD and MOG, you let me know, and I will continue to make videos on the topic. That was a great question, and thank you very, very much for asking it. Let's change some things up here. Let's go to this scene just to make things a little bit sassy and different. And let me look for a question from the audience. This is a great question from Pace Carley. So Pace Carley says, what are your thoughts on starting a disease-modifying therapy for radiologically isolated syndrome? And my short answer is I totally recommend that you do that. But let's talk a little bit about it. So RIS stands for radiologically isolated syndrome. And it's a phenomenon where the human being has not had an attack, but they have spots on their brain or spinal cord that look like they have multiple sclerosis. The human being does not have changes on their neurological examination. So when you run them through the MS Olympics, you don't find deficits, but they have spots on their brain that look like multiple sclerosis. And when you study people with RIS, a portion of them go on to develop multiple sclerosis. About 1/3 goes on to develop multiple sclerosis. And so the question becomes, what do we do with those people? And there are some MS neurologists that just watch and they don't do anything because they say, oh, well, only 1/3 will go on to have MS, so we don't have to use the medicines, which to me doesn't make a lot of sense. Because we know that the earlier that we start treatment, the better someone's going to do. So when I identify someone with RIS, I talk to them about starting an MS medicine. That is my style. It doesn't make me right. It just makes me very opinionated, but I can defend my position with data. That I think the better part of valor is to start treatment. I think the earliest that we start treatment, the best that people do long term. And I'm not saying that you have to go on treatment, but I am saying that I want to have the discussion with you about it. We've been doing this now for just about an hour. I've had a great time having coffee with you. I am so appreciative that you jumped online with me on this impromptu Ask Me Anything MS, this Sunday morning coffee talk. Thank you for participating in the chat, and thank you for the hearts. Thank you for the thumbs up. Thank you for supporting this channel. Before we wrap up today, do me a favor and let's tweak the YouTube algorithm. Throw some love in the chat. Make a comment, make a thumbs up, hit that heart button a bunch of times. Those actions teach the YouTube algorithm that you really like this content and help push it out so more families impacted by MS can benefit. I have been making YouTube videos every Monday going back to 2015, and I'm going to continue to put out content as long as you guys find it valuable. And it's my goal that we can reach as many families impacted by MS. So if you have friends and family in your village that don't know about the channel, throw them a link and ask them to check us out so that they can up their game and learn and be better at supporting you and your family as well. Now, today is Sunday. Tomorrow morning, I will be putting out a YouTube video, which will go live at 6 a.m. tomorrow, Monday. And until then, this is Aaron Boster, hoping to energize, hoping to empower, hoping to educate, and hoping to up your game. Thank you very much for being with me today. Thank you for supporting the channel every day. And I look forward to seeing you guys on our next live stream. Have a great Sunday. Thanks for having a cup of coffee.